talk about some prevention strategies during the perinatal period and early childhood. And I will try to provide a kind of an overview of the more recent intervention projects. There are several ways of thinking about prevention. The most ambitious is just the promotion of health, doing things that might lead to better health outcomes, in this case mental health or emotional health. And these are programs that intervene before there is any chance of a condition or a disorder from developing. Things that might make us better parents or have better outcome with the babies. And usually they are more on the lines of educational programs or awareness programs. And it's hard to demonstrate that they have a direct effect. Programs such as, for instance, the programs to prevent teenage pregnancy in the US might be a sort of a primary prevention program, but they have not shown a great deal of success. Whatever one does to raise awareness of the need for abstinence or anti-conceptive measures, etc., the programs have not been very successful to prevent teenage pregnancy, for instance. Secondary prevention is the second form of prevention. This one is more widely practiced, and in this form one intervenes with a population at risk to develop a condition or a problem, and one detects the early manifestations of that before it develops into a severe problem. One intervenes with a population that is at risk, at greater risk to develop it, hoping to be able to curtail or curb this problem from developing. And we'll talk about several of those secondary prevention programs. Finally, tertiary prevention usually refers to more what the medical model does, which is curing diseases and rehabilitating. Once the manifestations are there, then one tries to restore the health of the person toward a good functioning. In the case of early childhood and the perinatal period, we think then again of trying to diminish any risk factors, and we know quite a lot more about what the risk factors for a condition are than we know about the protective factors. We know quite well really what are some of the ingredients that will promote children having problems. For instance, we know poverty, high number of children, close space between children, maternal depression, high level of psychosocial stress, history of losses, coercive parenting on the part of the parents of children, negative experiences, traumatic experiences, loss of a parent. All of these are clearly well-defined risk factors. Others are, for instance, in preschool age, impulsiveness, hyperactivity, lack of fear have been shown to be associated with a higher likelihood of developing disocial behavior later on in life. So one of the issues that is crucial is if we know that some things are quite negative and put the child at risk, we should try to alleviate those, hoping they will have a protective effect. It's important to highlight that the stressors and the risk factors seem to have not only an additive effect, namely if you have 2 or 3 it's worse, but they have a multiplying effect, meaning after a certain number of stressors, if one has to cope with them, then the risk is much higher, not arithmetically but in terms of multiplying the effect of the risk. So some children might come to this world with the odds stacked against them because they have multiple risk factors, and we should try to intervene in those times, in those situations. So let's move on and talk about a few of the experiments or intervention programs that have shown some degree of preventive effect or which could be used readily in many settings. For instance, Hans Christoph Heinecke in California has shown that even before the baby is born, when a couple is preparing to have a baby, to have some marital therapy might have a protective effect for the child down the road. For instance, he showed a better more secure attachment behavior in the children of couples that have been exposed to marital therapy, along the lines of conflict resolution, promoting better communication, more cooperation between the spouses, and also these parents turned out to be more sensitive to the needs of their baby. There is now more and more interest in interventions during the pregnancy itself. Our group here in Topeka and other groups like the group of Dr. Barnard and Dr. Solchenyi in Washington implement interventions during pregnancy. We designed a model called the PREPARE program, where we meet with pregnant women in groups, really with a small psychoeducational component, showing them themes about the emotional life of babies, how to deal with crying, with feeding, with sleeping, with discipline in toddlers, and also what are the emotional needs of mothers and fathers during pregnancy, how to relax, how to be mothered during the pregnancy. And we also hope to promote bonding and relatedness between the different couples that are expecting a baby, hoping to alleviate the isolation, which we know is one of the risk factors, psychosocial isolation for parents of young children to develop problems. So in this way, we try to promote kind of a protective network about talking about what's going on and the fears and problem solving. Dr. Barnard and Solchenyi in the state of Washington, they use a program called Coaching and Promoting Maternal Attachment to the baby. They also emphasize a lot dealing with the emotional needs of the future mother, the transition to parenthood, thinking about the needs of the baby, and preparing and picturing how the baby will be, connecting with family members, thinking about family traditions, writing a letter to the baby, and reflecting on how the baby will be like. Again, this focuses the attention of the group or the future mother on her needs and the needs of the baby. During the neonatal period, Rao and his group have shown that very simple interventions can have a lasting effect, perhaps because this might be a sensitive period where parents are highly sensitive around the time of the delivery, and shortly after, parents usually remember everything that happened, all the details of what the nurses said and so on. So this group did a Braselton behavioral assessment of the baby, trying to convey just the idea that the baby is a unique person from the start, with preferences, with a style of relating to the world, and they showed a positive effect in parents who had witnessed this neonatal assessment in terms of a better parent-child relationship several years later. John Kennel and his collaborators, as well as Marshall Klaus, two pediatricians, have worked in the area of bonding in the 70s certainly, and continued work has shown the importance of the perinatal period. The work of Dr. Kennel, for instance, with doulas, who are women that support the woman who is delivering a baby, as well as the work on the bonding, not separating the baby from mother, creating a baby-friendly hospital, that is a caregiving that is friendly to the needs of the baby, where the mother is not disturbed and separated from her child from very early on, but they are allowed to be together in skin-to-skin contact, where the mother can get to know her baby, and when the doula has helped to have a better experience of delivery, this group has shown more maternal sensitivity, more patience, and a better parent-child relationship compared with groups that did not have the intervention. In the US, there is increasingly more and more interest in home visitation programs for a population at risk, of course. This has been difficult to demonstrate a positive effect uniformly, and it's hard to know what are the ingredients of a successful home visitation program, but given the fact that many more families are nuclear in the US, where there is little contact with the extended family, the contact with a supportive person who will assist with problem solving, who will be helpful to solve problems with the baby, who will give advice and support, seems to be a very important intervention. Dr. David Olds has shown some positive outcomes when the intervention is carried out by a nurse, perhaps because of her degree of knowledge of medical issues, the social status of the nurse, and the fact that they are accustomed to problem solving, to bringing resources to a situation, and they have a great deal of knowledge about health and the needs of babies. So these programs, when carried out by nurses, are promising in terms of somewhat better cognitive outcomes of babies and better parent-child relationship later on in life. The Vermont Infant Study Project also used a home visitation program, and they emphasize problem solving and support of the new mother, and showed better outcomes 7 years later in terms of better academic progress of the child and better psychosocial functioning. It is hard to evaluate home intervention programs because there is flexibility often in the approach, and there is a wide variation on what the home visitors do with different kinds of families. In a situation of poverty, another strategy developed by Brooks Gunn and her colleagues, they did an evaluation of a multicentric study in 10 centers with 985 families. They taught what about the development of the baby, the health needs of the baby, the emotional needs, and also the intervention involved some play with the baby himself and daycare for the mothers who want it. Daycare of a good quality can have a protective effect in babies who are at risk, like in these situations of poverty. This is what the study showed. A recent meta-analysis by Marinus van IJserdon in Holland showed that for certain families the home visitation programs are more successful than for others, and he suggested that the meta-analytic study suggests that practical recommendations are more successful, and problem-solving strategies on site, concrete advice, that intervention of home visitation is focused and brief, is better, probably with the families that have more strength to begin with. We will see that this model of home visitation is quite successful with these families, but with families who have much more deprivation and more multi-problem conditions, they need more an ongoing program of home visitation with concrete help, problem solving, and promoting parental sensitivity, because these are the families that are at risk for abuse or neglect of the child, and the only interventions that have shown any promise, according to a review of Macmillan recently in Canada, is extended programs of home visitation with parents with fairly concrete advice, and it has been better than other interventions that involve teaching parents in classrooms. Other interventions more focused are interventions for sleep and for crying. Several researchers have shown again, when there is a concrete problem, a brief practical program of home visitation can be helpful. In terms of interventions that promote better cognitive development, the Abecedarian project is very well known. It has been evaluated by Campbell with poor families, and in these families there was affordable daycare of a good quality and problem solving around stressors. These children showed better IQ, better attitude toward learning, and a desire to learn when they were studied 12 years later compared with a control group. And there have been other programs like the Yale Child Welfare Project and the Syracuse University Family Development Research Program that also involve some kind of support for the new mother, support for the role of the transition to parenthood, and some form of daycare of good quality for families that are at risk. That can have a protective effect both in terms of helping the mother to get a break from the situation and help for the children to have an enriched environment where they can be attended to and dealt with sensitively. Well, this is an overview of these programs. Thanks.